The COVID-19 pandemic continues to spread worldwide with more than 3 million cases. The problem is that transmission of infection from pre-symptomatic and asymptomatic persons is of great concern. Countermeasures until now are not available. Infertility is an essential service, but it represents a risk of patient and staff exposure. What are the international recommendations actually in this area? The ASRM recommendation, ASRM, is suspending initiation of a new treatment, cancellation of all embryo transfers, continuing in cycle, urgent stimulation and cryopreservation, especially for onco cases, suspending elective surgery, and increasing telehealth. For the European recommendation, we have to do an adaptation of ART services, sanitation, staff and center adaptation, limitation of the number of persons, provision for protective equipment, and redesigning the waiting rooms and working spaces. What is also useful is to use a triage questionnaire to select the patient at high risk of COVID-19 and to do the test, and if it's positive or the symptoms are here, to cancel the treatment and to do it after complete remission of the pathology. The problem is that COVID-19 pandemic will be with us for some time, and it could be here at least until an effective vaccine is available. So we have to consider strategy and best practices to continue to do fertility treatments in the face of COVID-19. The infertility is a disease. It's not something else. So we have to do it, even if there is a pandemic problem. But we should restart our clinical indication with some regulation. However, vigilance and measured steps must be taken for safe practice. Is there a place for telemedicine in infertility? What are the best new recommendations for the safety of both patients and staff in infertility treatment? Is there any effect on infertility and miscarriage due to COVID-19? All these problems will be discussed by our eminent speakers. I will give the floor to Dr. Naba, the General Secretary of the Lebanese Fertility Society, who is the chairman of this webinar because Dr. Azouri couldn't make it for familiar reason. Dr. Naba will explain our strategy of moving toward virtual world in our society, Fertility Society. He will also explain the technical guidance of this webinar. Last but not least, we want to thank Merck for making this webinar happen, and I hope you will enjoy our webinar. Thank you.
Good evening, ladies and gentlemen, dear friends and colleagues coming from different countries of the world. Before I start, I would like to thank all attendees for attending our first International Fertility Society webinar, which is sponsored by Merck. As a matter of fact, the COVID-19 pandemic has already spread to more than 100 countries around the globe, and physicians are facing major challenges in their daily practices. It is a particularly difficult time for IVF centers as well as for patients dealing with fertility treatment. In line with its commitment to provide all members with the latest updates in support for the infertile couple, the Lebanese Fertility Society is planning for a series of webinars tackling hot topics in the different fields of fertility management. So as you see, we're going to make a shift in this period from the conventional mode to the virtual mode. But is this a good or right thing? Once upon a time, Churchill said, there's nothing wrong with change if it is done in the right direction. So what are the different strategies our society is having during this era? It is moving from conventional towards virtual. This action has three main pillars. The first one is the virtual meetings. The second one, the social media. And third, the website. As for the virtual meetings, we're going to start a series of webinars at the rate of 1 to 2 per month, tackling different aspects of fertility management. A second pillar in this respect deals with the patient awareness conference and campaigns. If you remember, 2 years ago, we had a very interesting campaign under the presidency of Dr. Azouri. It was about infertility is a disease and its treatment is a right. And during this period, we are having different ideas about awareness related to fertility preservation after cancer treatment, for example, or for social freezing. The third cornerstone of the virtual meeting deals with the annual Congress. As we know, every year we have an annual Congress, Lebanese International Fertility Summit, and this is gaining more and more reputation and attendance. So if the circumstances are optimal to have it by early October 2020, that's good. Otherwise, we're going to shift towards virtual. In terms of the website and social media platform, we are working on the website, the Facebook and Instagram, and we are asking our friends and colleagues and members to go and connect with us, and we are ready and open to any suggestions or communication. As for the attendees to this webinar, although the majority are from Lebanon, but we have a big amount of attendees from Syria, from Jordan, from Saudi Arabia, from France, Romania, and UK. The sponsor for today is Merck. As you know, Merck is a supporter for all scientific evidence-based medicine seminars and meetings. So we thank Merck for this continuous support. We have rapidly few technical guidelines for the panelists. Please mute your microphone during the meeting when you are not presenting. And remember to unmute when you are talking. This is very important. Pay attention to the muting point. Turn on the video cam. And if you have any technical problems, please let SciencePRO that you have a technical problem and stick to the time allocated for the agenda. As for the attendees, you should note that this meeting will be recorded and shared on LFS YouTube channel and social media platforms. If you have any questions, you can make your presence known. You can participate by raising your hand for questions and comments, and we will give you the privilege to talk. Finally, you can share your questions in written in the section Q&A, and we will try to address them all at the end of the conference. Let me have the honor to introduce the first speaker. First speaker is Dr. Walid Ghutmi. He is the president-elect of our society. He is the chairman of EVE Fertility Center in Beirut and in the Gulf, and he is the president-elect of our society, as we said. And he's going to talk about telemedicine and infertility. The floor is yours, Dr. Ghutmi.
Thank you for inviting me to be part of this webinar. designed to shed the light upon a relatively new mode of practice, which I hope will outlive the current COVID crisis, pending necessary legislations needed for validation in each country. Now, probably the first form of telemedicine started around 50 years ago, or even 60 years ago, in the late 50s, when a small closed circuit TV link was established in the US between the Nebraska Psychiatric Institute and Norfolk State Hospital for psychiatric consultations. However, the real boost in the use of this form of medical practice occurred with the introduction of two factors. The first is the internet in the early 90s, and the second, the new legislations which allowed the reimbursement of telemedicine consultations. Now, telemedicine is defined as the use of electronic information and communications technologies to deliver healthcare to patients at a distance. Now, this is intended to ensure the uninterrupted care of patients while avoiding the unnecessary visits to clinics or hospitals, just like the current COVID-19 crisis. Now, telehealth includes the assessment, the diagnosis, consultations, as well as treatment and education and prevention in medicine. It involves the patient and the doctor or the healthcare provider, and the patient is called the originating site. The doctor or the healthcare provider is called the distant site. Now, in telehealth, the transmission between both sides is live, and thus it's very essential that when we talk about telehealth, we're talking about synchronicity of transmission between the originating and the distant site. Now, this is what happens in real-time video conferencing, which is becoming very popular in reproductive medicine and is covering such a wide range of acts, including new consultations, follow-ups, history taking, discussion of laboratory findings, and agreement on plans of management. Now, some patients are now physically meeting their doctors for the first time during an IVF procedure or an intrauterine insemination, having had all the preceding steps done via video conferencing and some follow-ups via WhatsApps and other techniques. Now, this has limited the need of frequent encounters, and this is very important now during this COVID-19 crisis. Now, it's very important to know that most infertility patients are labeled as low risk, and so no triaging is necessary to conclude them. No triaging is necessary to conclude that none of them requires urgent check-ins at clinics or at hospitals, which makes our specialty or subspecialty ideal for telemedicine application. Now, in telemedicine also there's a second mean which is very popular here in Lebanon, is what we call as store and forward technologies, or what we are used here as WhatsApp. When a patient sends you a WhatsApp and you answer her back, this is called store and forward technology. But the difference is that in other countries like the US or England, Australia, Scandinavian countries, all of them has made legislations for such mode of service, and these are reimbursed by insurance companies. Now, the store and forward technologies are an asynchronous form of medical services, which obviously doesn't hold the same quality of a face-to-face or a synchronous online consultation, but it helps in matters like taking a second opinion, like sharing information about a patient between two healthcare providers, like an analysis of laboratory and X-ray tests, and it's essentially used mainly, as I said, between a provider and provider rather than between a provider and a patient. Now, a third mean of telemedicine, which is not really relevant in our practice, is remote patient monitoring, which has no role in reproductive medicine, but rather in specialties like cardiology, endocrinology, neurology, where you put a monitor with a patient and you monitor her remotely, her or him. Now, until now, what we have said is La Vie en Rose for both patients and doctors. However, you should know that while we are already offering this service, mainly the store and forward technology for our patients for free, despite all the liability that it implies, most, if not all, health authorities around the world have made the necessary legislations which already made telemedicine not only reimbursed financially, but also approved legally, which removes any liability from the back of the doctors. Now, insurance companies, to go a little bit into details, for example, they pay on average in the US for a consultation up to 5 to 10 minutes consultation, they pay like $17 to $18. They pay 75% of this for a WhatsApp consultation, and the fee goes up until it reaches like $40 per consultation if the consultation reaches like 20 minutes. Now, in the US, Medicaid, for example, expanded the coverage of telehealth services to include all the services that are mentioned to be covered under your personal health insurance. Anything which is mentioned there is covered by telehealth. And that was well before the COVID-19 crisis, which means that it had nothing to do with the COVID-19 crisis. Now, to make patients happier, this also includes phone consultations. However, the phone call should not be more than 7 days, should not be less than 7 days within the last office visit. And as I said, these are reimbursed at 75% of the regular office consultation rates. Now, during the COVID-19 crisis, the guidelines as published by the ASRM and ESHRE are mainly to hold all types of assisted conception techniques, including IVF, inseminations, and related procedures. And some authorities have allowed the initiation of cycles mainly for cancer patients and frozen cycles. Now, nowadays, telemedicine is mainly offered for the following acts: initial consultation, follow-up consultations, discussion of laboratory and radiology results, and agreement on plans of management. Usually, the patient is forwarded a blank new file few days before the consultation, and she and her partner should fill all the personal information on this file, and including her past medical and surgical history, as well as her obstetrical, gynecological, and ART history. She should describe her chief complaint, and along with her partner, she should sign a consent for use of video conferencing for consultation. And she will choose on this whether to record it, not to record it, etc., and so many details, as mentioned by the legislations of each country in question. An insurance approval form is also provided to the patient, and thus all is set for the initial consultation, which usually lasts somewhere between 15 to 20 minutes. Now, further studies may be requested during the consultation, and a follow-up consultation is scheduled for the next 2 to 3 weeks. And the follow-up consultations are usually intended to discuss the laboratory and X-ray results and to make an impression which is reached online and a plan of management which is discussed with the patient. The patient is then set for treatment and is explained the steps which are now to be completed at the office. Now, in our practice, this is very important to ensure that neither the patient have failed to show up, nor the doctor have failed to offer their clinical services, and thus it is only a matter of accumulating a load of patients who are waiting to start the treatment rather than risking a fading practice which may be lost in case the crisis continues for more than 3, 4, 5 months. Now, I hope we shall be able to start telemedicine at our country, at our region, in an effective way. And I urge each one of you to start thinking of ways to implement legislations, or at least to push insurance companies to cover such treatments. I've been told not to speak for a long time, and I thank you very much for allowing me for this time.
Thank you, Dr. Ghutmi, for your excellent presentation. We're going to proceed now to our next speaker. Our next speaker is Dr. Salim Bassil. He is an obstetrician and gynecologist and IVF specialist. He is the head of the department of the IVF unit at Arz Hospital, and he is going to talk about COVID-19 and safety in infertility. The floor is yours, Doctor.
Thank you, Toufic, for your presentation. I want to welcome every attendees. I'm going to share my screen. I thank the Lebanese Fertility Society for their invitation. Okay, you have my slides?
No, not yet, Salim.
It's okay now. Share. Voila. So, as Professor Abitayeh said, now with the era of the COVID-19, I think we have to continue our practice with this virus for a long time. So, during the confinement period, it's normal that we are adjourning all the procedures we are doing, but we cannot continue, as Dr. Ghutmi said, for many months like this. And we should have our conditions to give care for our patients with the COVID-19 presence. So, if we want to address a protocol for safety about pathogen, we have to get the more information we can about the disease and how it spreads. What is coronavirus? What are the symptoms, ways of contamination, methods for virus inactivation? First thing you have to know that the coronaviruses are RNA simple-stranded viruses. We have 4 genera of coronaviruses: CoV, alpha, beta, delta, theta, gamma, and delta. Alpha and beta are the more frequent in humans. This is why we call them HCoV, human coronaviruses, and they are known since 1960. Beta is the more frequent human CoV, responsible for SARS in 2002, for MERS in 2012, and for SARS-CoV-2, the COVID-19 now. The specificity of the first two, they have a high rate of mortality with a low infectiosity rate. The specificity of the COVID-19 is the low mortality and the high infectiosity rate. Now, genomics of the COVID-19 are 86% identical to the bat SARS coronavirus, and it is different from the SARS-CoV and the MERS-CoV. Manifestations mainly are fever, cough, sneeze. Less we can find conjunctivitis, ageusia, anosmia, etc. The incubation time in median is about 14 days, but it can last also for 21 days. The main issue is that 80% of affected persons have mild to no symptoms, and up to now we don't have any precise percentage about the asymptomatic persons carrying the COVID-19. 15% of those persons will need hospitalization, and 5% will be affected to ICU units. The specificity is the highly infectious during asymptomatic incubation period, which is different from the SARS-CoV, which is not asymptomatic, or it's not infectious during incubation period. It's only infectious during symptomatic periods. There is low concentration of viral RNA in blood, and the very high concentration of viral RNA in the upper respiratory tract. The inactivation of the human CoV is via the acid pH variety of alcohol of hydroalcoholic gel, and we should have an hydroalcoholic gel over 80% concentration of alcohol, and basic pH also can inactivate the human CoV. Soap cleaning solutions are enough, but we should wash for 20-second time. The heat also inactivates the HCoV at 60 degrees for 15 to 30 minutes. The ways of contamination is specifically with the droplets, because the concentration of viral particles are high in the upper respiratory tract. Droplets during cough, sneeze, or even talk are highly contagious. The concentration in non-respiratory specimens are very low. And according to a study in the JAMA in 2020, 2 months ago, Wang demonstrated that with COVID positive patients, we can find the viral RNA in 29% in patient in stool, 1% only in blood, and none of those patients have viral RNA in urine. We don't have any data about follicular fluid. When we look to the ways of contamination also, it's important to go we go to Lee here and al, because it is the only one who did, all those are done on coronaviruses before, and this is done now on CoV-2, on SARS-CoV-2 with the COVID-19, and we can see that the spread of droplets can go up to 3 meters. On surfaces, the viral particles was discovered after different lapses of time according to the type of surface. On these surfaces, what is important to say is that the NA titer decreased by 66% after 1 hour and by 82% after 2 hours. But it's important also to know that we don't know if those RNA titers are infectious and if they can induce a clinical infection. Here we can see on different support how long can stay the viral, we can find the viral RNA on glass, on gown, on gloves also. It's very important. Now the ways of contamination, we even all in the USA suggested that the laboratory acquired infection when working with specimens containing, with respiratory specimens containing human CoV are rare. The few cases they encountered were attributed to break in biosafety practices. The conclusions that we can say is aerial transmission is considered the major exposure risk to COVID-19. Contact with the upper respiratory tract is the main entrance. When we have laboratories, they are processing a respiratory specimen, we can say that they are lab at high risk. The laboratories processing other biological material are at low risk. In any way, we can have to continue our routine biosafety guidelines in the laboratories. Now, for us, what is the main issue? Who are the personnel exposed in daily practice? The clinical team, the paramedical team, and also the administrative team. During consultations, what we can say, it's routine disinfection of surfaces, door, handles, sinks, desk, etc. are very important. For the administrative team, pre-appointments, we are distancing the appointments. We inform patients that no handbags or wallets are allowed in the office. They have to keep their cell phones in pockets or in the car. At reception, body temperature measurement are done. Screening questionnaire is asked for all patients, if they have any relatives, they have any symptoms, we ask them to remove the gloves at the door, to throw them, and they have to disinfect their hands with hydroalcoholic gel. The face mask must be well positioned. It is not face mask for show, it's for protection. And we are spacing patients in our waiting room if we have more than 2 couples waiting. As I said in the beginning, we are distancing the appointments. So up to now, we don't have more than 1 couple waiting in the waiting room. In office, we keep distance for 2 meters between the practitioner and the patients, no handshakes, and we keep the face mask. For ultrasound, also we have high risk of contamination. We should have the routine disinfection of surfaces. The risk is because we have physical proximity. Usually the machine is in a small enclosed room. We don't have ventilation. The examination time may last sometime for more than 10 minutes. The woman might be asked to exhale or inhale, and sometimes they exhale or inhale spontaneously. So risk of patient coughing or sneezing. And also we are touching the surface of the ultrasound machine frequently. The prevention is to make a surface disinfection, as I told in the beginning, the triage before the patient come in, the ventilation of the ultrasound room. If we don't have an AC with a HEPA filter, we have to open the door or the window. This is efficient, really efficient for the aerosol particulate. Keep 20 minutes between each exam for ventilation, and a surgical mask with hand wash after each exam. The gloves, if we are using them, it should be done a single time use. For surgery, we keep the OR protocol routinely for disinfection of the OR room. The prevention of anesthesia is done, applied by the anesthesiologist. They have their own protocol. For the surgery, for us, the surgeon processing is very important in the protection ways. The donning of our clothes, after washing the hands, we put the mask, the goggles, the operative gown, and at the end, the gloves. The operating field should be disinfected as usual. And also when we are removing our protection, personal protection, we have to remove the gown, the gloves, wash our hands, remove the goggles, and we should change our face mask. Working with a high efficacy particulate air, the HEPA filter, as I say, combined with the PPE, provide adequate protection. And also our surgery room should be with a negative pressure. Well, we should know that with this negative pressure and with the HEPA filter, a single air change removes 63% of airborne contaminants. After 5 air change, only 1% of airborne contaminants still detectable in the room. Here where you have the chart of the patient about the dressing, and then after we have the chart of the undressing after a surgery or after an operation. For assisted reproductive technologies, IUI or embryo replacement, the risk is like ultrasound. We have a physical proximity. Usually the rooms are small and enclosed. The examination time may last sometime for more than 10 minutes. The risk of patient coughing or sneezing when we are manipulating. And also, if we do this under ultrasound, the surface of the ultrasound machine is touched frequently. So we have to make a surface disinfection. The triage also, before the patient enter, can give us an idea if they are contaminant or not. We have to make a ventilation, good ventilation of the room, open the door or windows if they exist, if there is no HEPA or AC. 20 minutes between each procedure for ventilation, and the surgical mask with hand wash after each exam. Here we have a table. It was done by Cheng and I in February 20, and we can see that what we have according to each area of risk of contamination when we are caring with COVID-19 patient, when we are in the triage station, when we are in the aerosol generator procedure in ICU on a hospital. Here what is our concern is other patients area and other areas, and what you see here, hand wash is required. Choice of mask is enough with the surgical mask. Isolation gown is not required. Disposable glove is not required. Eye protection not required, and hair cover not required. So for our practice, this is the area of concern. Here we have the different type of face mask we dispose, and the surgical mask is enough for our practice. For the lab, so we have to make a routine disinfection of the lab by the lab protocol. According to the information about the virus spread and infectious contamination capacity, a facility-specific risk assessment should be considered. Even if we consider our lab as a low risk, we should identify the hazard and inform and train the personnel. Because we are dealing with a virus, it's a new pathogen, and each day we have a new data about, and we have a new volume. We don't know everything about the COVID-19. So to identify the hazard, we have to focus the risk, identifying the virus, classify the potential of exposure, and identify the activities that may increase the risk of exposure. We have to put strategies for the risk mitigation. So we have to identify a required safety practice to address the risk, personal protection, equipment, generic control, determine whether other mitigation strategies are needed. If we need a new equipment in our lab for HEPA filter, upgrade our equipment, and provide communication to staff on risk. They should know what is the risk in order to apply or the procedure correctly, and validate those strategies with. So also the other thing, we have to inform and train the personnel. The training, we have to show them how to properly collect the specimen, the donning and doffing of the PPE, the equipment, centrifuge with sealed rotor, to work with the biosafety flow cabinet, and the inventory control. We have to adequate supply of specimen or collective device. We have to make an appropriate disinfection of material. And also what is important, the adequate transport material for on-site when they are delivering us material. So for the lab, we can say that regular disinfection is important. Patient went through the triage procedure for the prevention. We have surface disinfection and PPE protection for the staff. What is important is single-time use surgical mask and gloves. After each procedure, they should throw everything, wash hands, and put another gloves and surgical mask again. The specimen recovery and handling, the sperm samples, it's very important. So now the disposal of the recipient and delivery of the sample should be on site. Hand wash, we should train the patient how to give their sample. Hand wash with soap for 20 seconds, wash the genital parts with soap for 20 seconds, and keep the sample on place. For the follicular fluid, keep surgical mask with face shield, hands wash with soap or alcoholic solution, and single-time use for gloves. So in conclusion, our practice is considered at low risk, but as I said, we don't know everything about the virus. We should manipulate everything with precaution. So general prevention measures should always be applied during the pandemics. Triage before entering the center or the consultation office. Face mask well positioned. Surgical mask is enough. Patient gloves removed before entry at the center, at the office, and hand disinfection. Distancing the appointments and patients in waiting room. Surface disinfection of furniture and medical material. Appropriate prevention in operating room, donning and doffing the PPEs, adequate ventilation of the examination rooms out of HEPA filter conditions, distancing the procedure of ART, appropriate handling of specimens and material, and keep PPEs available with respect of efficacy duration 4 hours for surgical mask, single-time use for gloves. Thank you for your attention.
Thank you, Dr. Bassil, for your outstanding presentation. As we said, we leave the questions till the end. Our next speaker is Dr. Antoine Abu-Musa. Dr. Abu-Musa is the Vice Chairman of the Obstetrics and Gynecology Department at AUB Medical Center. He is previous head of the Lebanese Fertility Society, President, and he's the head of the division of the Reproductive Endocrinology and Infertility at AUB. So he's going to talk to us about COVID-19 and miscarriage. The floor is yours, Dr. Abu-Musa.
Thank you very much, Toufic. I would like to start first by thanking the Lebanese Fertility Society and, of course, thanking all the I'm trying to share my slides. Is it okay now?
Yes, yes, Tony, it's okay.
Okay. Good. So again, thanking the Lebanese Fertility Society for the invitation, thanking Merck for the continuous support for our educational activities. And as the theme of this seminar is the infertility in the COVID-19 era, I was asked to talk about miscarriage with COVID-19 infection. Well, actually, this is an easy and difficult topic. It's an easy because you can just end it in a couple of slides, and it's very difficult because the data available about this issue at the present time is very scarce. So I want you to bear with me with some of the things that I'm going to talk about. I'll try to cover with my presentation infertility in general, IVF in general, and miscarriage in general in COVID-19 infections. Well, yes, this is the era of COVID-19. All the world are talking about this virus, about this infection. It is something which is completely new to everybody in the world. It is really unprecedented. There's no living person on earth who had experienced similar pandemic. There's a lot of unknowns, there's a lot of questions. It turned out that we, as a world, are not ready for this pandemic, and this has caused a lot of panic, fear, and stress among the population of the world. As I said, we are learning on daily basis something new about this virus. From infecting a tiger in New York to the 3 different types of viruses that we have, the 3 different strains, the way they have spread all over the world, and even which country with which virus is being infected. So on daily basis, things are changing, information is changing. So whatever we speak even today might change in the coming 2 or 3 weeks from now. What I believe is important during a pandemic, and this is, as I said, all of us are living for the first time in a pandemic, there are 3 basic rules that I believe should be followed. The first and the most important one is to take it seriously. And any country that did not take this pandemic seriously ended up in disaster. So rule number 1, it is a serious thing that should be taken into consideration. The second is that we don't need to wait until all the facts are available in our hands in order for us to act, because sometimes they come late. And during pandemic, things usually move very, very quickly. And that's why we need to use common sense. And as Anthony Fauci said, historical evidence rather than evidence-based medicine in the treatment and in the battle against pandemic. Of course, we like to have the evidence-based medicine ultimately, but we don't need to wait till we have this for us to act. Things have been going very fast. This is almost 1 month after reporting the first case in China. It was still called the Wuhan coronavirus. This is January 25, localized mainly China mainland. In 6 weeks, it spread all over the world with almost 200,000 cases, almost 8,000 deaths. And just 2 days ago, or actually yesterday, more than 3 million infected and more than 200,000 deaths. So this tells you how things are moving really very fast. And because this is new and because it is spreading fast, we had to resort to the traditional things, basic things that everybody has done in previous pandemics throughout the history. And this is to overreact to this pandemic. And whenever you are overreacting, you are doing the right thing. And what I mean by overreacting, it means staying at home, wearing masks, social distancing, this might be overreacting to some people, and some people still debating whether this is important or not, but overdo it better than not doing it at all. Well, what about COVID-19 and infertility? Of course, data is not available, but we all know that the ACE2 receptor, the ACE2 receptor, which is the receptor needed by the virus to invade the cell, is present in the testes, in the ovaries, and in the endometrium. We know this for sure. But we also know from the SARS epidemic that these organs were never infected. They didn't find any viruses in these tissues that I talked about. So it is believed, because COVID-19 is very similar, almost 70–80% of the genetic makeup and having similar receptor, it is believed that the COVID-19 will have no effect on male and female reproductive system and therefore fertility. Of course, there's no evidence, there's no data, there's no studies, but at least based on historical evidence, as we said, believing that and knowing that SARS did not have any effect, we tend to believe that COVID-19 will have no impact on the fertility. Well, what about IVF? This was mentioned early during the seminar, that the two basic, or the biggest societies of infertility in the world, which is the European Society and the American Society, they came up with clear guidance. And basically they're almost the same. The ESHRE, they have recommended that no new cycles should be started during the pandemic. In case a patient has already started a cycle, then yes, she can continue, but do not continue into embryo transfer. So freeze all embryos. And the only urgent cases, according to the ESHRE, are the patients who are oncology patients. Oncofertility patients are the only patients who will undergo such treatment during the pandemic, mainly for fertility preservation. Well, the Americans, they said almost the same, but they went a little bit further, saying that when they say urgent cases, it is yes, the oncology patients, and they stress that patients who have low ovarian reserve or elderly patients, they are not, and I repeat, they are not urgent cases. So according to the ASRM, these patients should not start any new cycles. We know that ovarian reserve is crucial, but waiting for 2–3 months will not have a major impact. In addition, they said it's not also good to do any frozen embryo transfers. And they talked about not doing any interventions, including hysterosalpingograms and so on. So the question is, why these societies said that we should stop doing our IVFs? And the answer is very simple. Simply, we do not know. We have no idea about the impact of the infection on pregnancy, especially early pregnancy. And we have no idea on the impact of the infection on the outcome of IVF. This is something new to us. Well, what about the contamination? People, they say, well, we have stopped IVF because we are afraid of contamination in our lab. Well, this is a very unlikely scenario. It's very difficult to contaminate our gametes and our embryos in our IVF labs. And this is for a simple reason. We do a lot of washings in our lab, washing and washing and washing of eggs, sperms, embryos. This will decrease a lot the risk of any infection. And if there is any contamination, it will be highly diluted. So there is no risk of infection, actually. And we have seen this in other epidemics. AIDS patients, hepatitis B patients, they have never reported any infection in a lab from these two epidemics. Add to that the sperm, the egg, and the embryos, they don't have the receptor for the virus to infect. They don't have the receptor that we talked about. In addition, the zona pellucida is very strong protective wall for the embryo and for the egg. And just 2 weeks ago, the Cochrane did a quick analysis of all the recommendations worldwide to see if has anything changed. Well, all societies from all countries in the world, they still recommend not starting any new cases in IVF. But just a few days ago, things started to a little bit change. The mood has been changing a little bit. And the reason for that is that we all know that COVID-19 is here to stay. It's not going to disappear in 2 months. So it's not logical to keep our centers closed indefinitely till the virus is completely eradicated or until we have a vaccine. In addition, people are still getting pregnant on their own naturally. So why we should limit pregnancy? The effect of the virus on pregnancy, pregnant spontaneously. And during an interview that I had today with one of the journals, they asked me this question: would you allow your patients to get pregnant on their own? I said, well, probably it's advisable not to get pregnant, but we cannot stop it. I think patients are going to get pregnant. And of course, as testing become more available, easy, I think we will be ready to open up our centers gradually. And we have moved in our center in starting having more elective cases during the past few days. Well, this is the problem of the recommendations and the guidelines that we have during a pandemic. As I said, if you want to wait for the guidelines, if you have to wait for the protocols, for the evidence-based medicine, evidence. Let's move now a little bit into pregnant women, a vulnerable group when it comes to infections. We know that at a high risk for H1N1. We know that they were very high risk for SARS epidemic. And this is known that, yes, pregnant women, because of the physiological changes, mechanical changes that happen during pregnancy, cardiopulmonary system changes, the immune system will change, and now the hypercoagulable state that the pregnant women, they have, and we know how much important it is in COVID-19 infection and the risk of death, then all of these factors will make the woman as a vulnerable patient. But at the same time, there is no data that will tell us that the pregnancy itself will increase susceptibility to the infection. Yes, they are a vulnerable group, but it seems that the data so far that pregnancy itself is not going to increase the risk of COVID-19 infection. We have always to think during pregnancy and any infection, especially COVID-19, what effect it has on the morbidity and mortality of patients, on the vertical transmission to the fetus, on congenital anomalies, and on abortions. Well, the COVID-19, the SARS, and the MERS, these are all coronaviruses. They are beta coronaviruses. And they have a genomic RNA that is present in them. It's a single-strand RNA. It is interesting to know that COVID-19 share 80% same genomic material as the SARS and almost 50% as the MERS infection or virus. So let's see how these different coronaviruses have been affecting the world. SARS, reported in 2003, again from China, infected more than 30 countries with more than 8,000 cases, 770 deaths, and no cases have been reported since 2004. So this was very quickly controlled. The MERS, which started in Saudi Arabia in 2012, infected more than 2,500 cases with 860 deaths. So the deaths with MERS was much higher than the SARS. And still, occasional cases are being reported with MERS. The COVID-19 is the newest coronavirus started in China, it spread all over the world, more than 3 million patients and more than 200,000 deaths. So as you can see immediately that the COVID virus is spreading more faster, more contagious than the SARS and MERS, but as we are going to see later, the death from this virus is less. And actually, the difference between them is, you can see in this slide. I'm interested in the mortality rate. With SARS is around 10%, with MERS reaches 40%, and with COVID-19, it is estimated to be around 1%. COVID-19 affects more males than females, while SARS had more infection in females. And it seems the age group for the COVID-19 is much higher than other coronaviruses. For us to be able to answer the question about the impact of the COVID-19 on pregnancy and so on, as I said, we have to use some historical evidence in order to conclude some things from this presentation. Let's see SARS, how did it affect the pregnant woman? The number of cases reported is very low. We're talking about 100 cases reported worldwide. And it seems that the outcome in pregnant women is much worse than non-pregnant women. They stay longer in hospital. They have risk of renal failure, sepsis, the IC, and more ICU admission. So pregnancy itself, yes, it was a major risk factor for a bad prognosis with SARS infection. The effect of SARS on the pregnancy itself, reported miscarriages between 40 to 60%, preterm deliveries between 30 to 80%, and maternal death rate 30%, which is much higher than the general population of 10% infected with SARS. So the mortality rate with SARS infection was very high. The MERS, on the other hand, very few number, 13 cases I could find, and they have been distributed in a few countries, and all of them, they behaved like non-pregnant. So pregnancy itself did not contribute to bad outcome with MERS, but anyway, the outcome of MERS infection was very bad in all patients, pregnant and not pregnant. Well, when it comes to COVID-19, what we know until now that the clinical presentation of a pregnant woman is similar to non-pregnant woman. There's no increased risk of having poor outcome with pregnancy itself. And it seems that the outcome of the COVID-19 is better than the outcome that we have seen with other coronaviruses, the SARS and MERS. According to, I'm going to share only 2 or 3 quick publications. This was published around 3 weeks ago, still under press. The complication from COVID-19, only 2%, IUGR 10%, and preterm birth 39%. Fatality rates so far in pregnancy, 0 in the COVID, 18 in the SARS, and 25 in the MERS. This is the second one. This is the most latest one. It has the highest number of patients reported, 116 patients. 7% had severe pneumonia. The miscarriage rate is only 12%, which is very similar to the general population. So it seems that there is no risk of having a spontaneous abortion with COVID-19 infection. And this is very important because this is what patients are asking us nowadays. Patient comes to us pregnant, newly pregnant. The first thing that she's going to ask us, what is the effect of the infection if I get infected on my pregnancy and on my baby? So until now, we can still reassure her that yes, there's still no increased risk of abortion with COVID-19. So as I said, according to this latest publication, there is no increase in risk of abortion, and it seems there's no vertical transmission of the virus to the baby. And we know this for almost sure. Although there has been reported some babies that were born recently that got infected within few hours after birth, not knowing if this is a vertical transmission or something that they got from the hospital. Most likely, it's not a vertical transmission in these patients. But still, we don't have evidence for that till now. This is April 9, just 2-3 weeks ago. The Royal College OBGYN, according to their update, information to the healthcare professionals stating clearly, currently no data suggesting an increased risk of miscarriage or early pregnancy loss in relation to COVID-19. And it seems that it is not teratogenic. Well, teratogenicity is important because we have seen it in Zika that led to a lot of abnormalities in the babies. So to conclude, yes, pregnant women are vulnerable population. They seem to be doing relatively well. They have no increased risk of having more complications than the now that there is no vertical transmission, and the data up till now
Hello. Thank you, Dr. Abu-Musa, for your excellent, outstanding presentation as usual. So now we're going to have a small video by Merck, and afterwards we're going to start with questions for the panel. Can we have the video, please? Thank you. Do you have any questions? I have a small question, if you allow me, to Dr. Abu-Musa. Thank you again for your excellent presentation. It looks like during pregnancy, there is no adverse outcome either in terms of pregnancy or miscarriage. But what was said about infertility was that when the virus entered via the ACE2 receptor the first time, but we all know that if the virus is going to recur, it is going to enter via another receptor. Does this have also another impact on the bad outcome on the infertility or the endometrium or ovary?
Well, as I said, we are learning every day something new about this infection, about this virus. So what applies for today might change, as I said, in just a few weeks from now. But it seems till now that things are relatively safe when it comes to pregnancy, to IVF in patients with COVID-19 infection. And again, I think the most important thing is when we start doing these mass screening, when you start doing testing and testing and testing for every patient that comes to the clinic and to the IVF center, we'll be able to probably control things much better.
Okay, thank you. Other questions?
There are some questions offline. So for Dr. Abu-Musa, someone is asking if regarding the sperm banking and egg donation, can this be affected by the current COVID crisis? And if we need any further tests in the future?
Yeah.
You should unmute. You should unmute if you want to answer, Dr. Abu-Musa.
Dr. Abitayeh, I can intervene. When we look to the data we have, there is no viruses present in the sperm or in urine. So up to now, with those data, we can say that this will not be affected. Okay, Dr. Abu-Musa came back. I will let him continue the answer.
Yeah, sorry for this interruption. But there was a recent report from Italy that has shown clearly that there was, in patients with COVID-19 infection males, no virus was detected in the semen. This has been reported just a few days ago from Italy. I think the problem is when you start doing the cryopreservation, is there a risk of having viruses frozen in your system? And most of the, nowadays, most of the freezing system is an open system. So viruses might probably from one place to the other, but still, this is just theoretical. But even if there is a virus which contaminates your lab, the freezing lab, then most likely with the washing that we use, even after we thaw all of our gametes, I think the risk of having infection is very minimal. We have not seen it in any other infections, especially AIDS patients and hepatitis B patients.
We have another question from one of our colleagues. She's asking, when should we open our labs? And is PCR a must? If yes, when should it be done?
Well, I think, as I said, now the mood is changing a little bit as far as opening the IVF centers. What we have been doing during the past 1 month, we have used our lab or our IVF facility only for oncofertility patients and very few selected low reserve patients. But we have started gradually moving more and more into the regular patients. I think testing, if it is available, is the key for any progress that's going to happen in the future. If it is available, and if this is the fast test, I think, yes, we can start opening our centers very soon, sooner than we predicted. We used to believe that it's going to take at least 3 to 4 months before starting our cases, but things are moving forward in many places around the world.
Sorry.
No, it's okay, but just we think we have to do PCR test for any procedure, for all procedures?
I think ideally, yes. I think all patients ultimately who are going to have any type of procedure, whether this is delivery, cesarean sections, IVF, any elective procedures in the future, we need to do the test, especially that we know now that the asymptomatic patient is a good number of patients are asymptomatic. Yes. So I think, yes, ideally it should be done.
A colleague is asking about whether we should decrease the frequency of ultrasound during an IVF cycle when we are using telehealth. I think this doesn't go together. Either you go for telehealth while holding and stopping the IVF cycles, or if you want to do ultrasound, it means that you started your cycles again. You cannot have ultrasounds with telehealth. And another colleague is asking if a patient, a male patient with male infertility, has a PCR positive test, but he's asymptomatic, is IVF contraindicated? Again, the current recommendations now are not to proceed with any IVF procedure for even PCR negative patients. So with PCR positive patients, I guess for sure you cannot start IVF even if he's asymptomatic.
There's also a question why ESHRE and SRM recommend to freeze all and to not transfer the embryos for patients without anesthesia. I think the reason is to protect the patient and the staff from asymptomatic person. This is the issue. It's not the transfer, the risk. The risk is to the contamination of the patient or the staff from person not symptomatic. So for distanciation and to avoid any contact between the patient and the staff, I think they recommend freeze all and to postpone the transfer of the embryos.
George, Dr. Abitayeh, this was during the confinement period. All activities, even I know in Belgium, even cardiac surgery and all those activities were stopped in order to define the hospital specifically for the COVID-19 because of disease. Now they are moving forward, as Dr. Abu-Musa said, and many centers are going to begin again their cycles with all safety measures said. So we should have in mind that COVID-19 is there, and we should make our practice according to this. For the PCR, I have another thing that even if we do PCR, it is negative. This doesn't mean that the patient is not positive COVID-19. So even if PCR is negative, we should take all the safety measures when we are dealing with the patients.
I don't think we are in a position to make guidelines. For example, for the colleague who's asking, is PCR a must and when should it be done? I don't think we are in a position to make guidelines. And why, another question is, why can't we proceed with frozen cycles? Another question is, why can't we give spinal anesthesia? I don't know who can answer this, but I believe that we cannot just find ways to proceed with cycles while the guidelines do not state this. What do you think, Dr. Abu-Musa?
Well, as I said, Walid, the guidelines are important, but sometimes in pandemics, you cannot wait for the guidelines to come. I think ultimately in 3 to 4 months from now, we'll have a strong guidelines with some evidence to practice. But during the process of the pandemic, when things are moving very fast, we have to use common sense. And that's why the first common sense that came to us is that we don't know what's going to happen to early pregnancy. We don't know if there's going to be abortions. We don't know if there's going to be any teratogenesis. So stop getting patients pregnant. Of course, there are other factors, including infecting the staff. And as Dr. Arif from Jordan, he asked a very interesting question. What would you do for a patient who you know at a later stage that has COVID-19 and you already did the procedure? What are you going to do with your team? And that's why many centers now, they are dividing the teams into 2 or 3 if they have the capabilities of doing so. And work for 2 weeks and then stay at home. Another team will come for 2 weeks and then stay at home. So these are some of the things, if the center can do that, the strategy that will help to solve the problem of the risk for the lab and the staff and the IVF.
So to answer their questions, for doctors who are doing IVF now and who are asking whether PCR is a must and when should we do it, and what they are asking whether to use spinal anesthesia, what would you tell them?
I can tell you at least we have never used the spinal anesthesia for a patient. All of our patients, they go for sedation, moderate sedation. So I don't think there's a need for any spinal anesthesia in any patient doing IVF.
To decrease the risk of transmission, maybe.
Yeah, of course, the transmission is more for the anesthesiologist group. The anesthesiologists are taking care of the patient. So I think if the patient is a risk patient, she has the symptoms, turns out to be positive, I'm not sure the spinal anesthesia is the way out. But when it comes to no guidelines that will tell you that you should do PCR for all patients. But if you want to take the Korean experience and the German experience, which means mass testing for everybody moving on the streets, this is the way that they could be able to control the pandemic in their countries and their areas. So I think ultimately with the new test and the rapid test, every single person who's going into the hospital for any procedure should do the test, not only for the sake of the patient, but more importantly for the sake of the staff and for the community of the hospital in general. Because in a pandemic, the community health is much more important than the individual health.
Any other question? There's only Dr. France is talking, telling us there is no proof of COVID-19 in sperm or ovule. There is only proof in follicular liquid. So, just an intervention from France. So it's important. Sorry.
There is also a question from Professor Arif Al-Khalidi, who is the president of the Lebanese, ex-president of the Lebanese Jordanian Fertility Society, excuse me. And he's saying he thanks the excellent presentation and the society. And his question was, what if our IVF team had an IVF patient that turned to be positive for COVID-19 after the procedure? Would you quarantine the whole IVF team and close the centers, or we should have a contingency plan to deal with such situation?
I think I mentioned this, that if the center has enough team players that can afford having team working for 2 weeks, then rest, and 2 weeks and then rest, I think yes, they can afford doing that. But this is a very challenging problem if it is faced. Ultimately, yes, you have to quarantine everybody, do the PCR test, and wait and see.
Other questions? Somebody was raising hands, but it was another question from a friend, embryologist. Were there any cases of ovarian hyperstimulation and COVID-19? And if yes, what was the prognosis? From Samuel Malou.
Well, I don't know of any reported cases of hyperstimulation during this pandemic. And probably this is one of the reasons that led most of these societies to suggest not doing IVF, in addition to not knowing the effect on the pregnancy and the IVF outcome, also the risk of hyperstimulation. But I'm not sure there is any reported case of patient with COVID-19 and hyperstimulation syndrome.
Okay.
Well, theoretically, just to continue, theoretically, it might be a risk because with hyperstimulation, there is an increased risk of coagulopathy and DVTs and so on. And we know that now one of the most important causes of death in this patient is the hypercoagulability.
Other questions? You should unmute. Dr.
Okay.
Abitayeh.
Okay, thank you. So I hope you enjoy our first webinar. I want to thank our speakers, attendees, and our chairman for all their efforts. I think COVID-19 will still here. We have to begin new strategies to open our centers with all new recommendations. Rapid test is a good idea. Questionnaire also for all symptomatic patients is very important, and to improve the safety conditions of our centers is very important also. Big thanks also to Merck and its team who helped us to make this webinar happen. Thank for SciencePRO also for all its technical support, and hope to see you with us for our next webinar. It will be Wednesday, 6th of May at 5 p.m. and it will be sponsored by IPSA. So thank you very much. Have a nice evening and hope to see you on Wednesday, 6th of May at 5 p.m. with IPSA, with new subjects and new challenges. Thank you very much and have a good evening.
Thank you.
Thank you.
Thank you.
Thank you. Have a good evening.
Thank you. Thank you.